Good evening, one and all. So this is now 7:30. We can start our this week's sessions. The routine thing, please keep your uh, connections as in muted stage because it interferes with others learning there. So please keep throughout the presentations muted. To get your attendance, please interact whenever questions are posted and keep asking the questions so that we can interact. And this session is basically topic about emerging and re-emerging infections. Since COVID is re-emerged recently or the last 1 month or 15 days so we are discussing COVID more focus. But otherwise, this is topic for emerging and re-emerging infection. That is the focus for your sessions. So without further wasting our time, I can start emerging and re-emerging infections today's session now. I sincerely thank AP and ICP for giving this wonderful opportunity. So participants, those who are logged in, please start answering the questions and post it there. So my objective today is why this topic, what is subsiding? People are always talking about emerging and re-emerging, but we have seen couple of diseases also subsided or subsiding now, and couple of diseases alone not. Couple of procedures also subsiding and subsided. I'll come back and explain what are all the diseases, what are all the things are subsided, and what is emerging and re-emerging, and I'll try to summarize at the end with focus towards COVID in the end. So I'll ask the participants, those who logged in early, can you name which diseases are re-emerging, not emerging, it's re-emerging. Can you put dengue, chikungunya? I think I need to check. Yeah, almost the house is full. So 57 people are logged in there. So how many say what are all the diseases are re-emerging? Dengue, chikungunya, mpox, COVID, Nipah, malaria. Which diseases has been re-emerged? I put all of the above, none of the above, except for mpox, COVID is re-emerging. I don't know. I just want to check what is your responses. Don't put your name to get attendance. Please interact with and get the attendance. That's what standard instructions we told. So please interact. Don't put your name in the chat box and getting attendance. Don't try for that one there. So that is most important thing. I'm waiting for the responses. So, people say 3. People say 1, 4, COVID is re-emerging. Fine. More responses to get. Fine. So those who are logged in, just answer this one. So now I think like 60 people have crossed it. Yeah. So I'll wait for a couple of more minutes before I just take a push inside. So, okay. For this, you need to answer these questions. You need to know what is emerging and what is re-emerging. That definition should be clear. I'll come back and explain. So what is emerging? For example, any infectious diseases that newly appeared in the populations are known for some time but suddenly start increasing in number. For example, in 2020, everybody knows COVID came. That's the emerging disease in 2020. Before that, that was SARS-CoV-1 and people have got MERS. But right now in 2020, we exposed SARS-CoV-2. The SARS-CoV-2 emerged in point of time in 2020. Suddenly came and started spreading like anything. That's called emerging disease in 2020. But in 2025, that is re-emerged. The disease was there. Suddenly it came down and again it started appearing. So if you go back to these definitions, for the first time it is happening, there is emerging disease. When it's emerged and again subsided, again it's coming back, it's called re-emerging diseases. So almost all the things are re-emerging to be dengue. Yes, it's coming down in every year, it's coming down, subsiding, again it's coming back. That's what dengue is happening. Similarly, chikungunya, 2007, 2014, again it starts happening now. Mpox not is a new disease. Mpox is an old disease. It emerged in example, the data of this disease person since 1920 years in mpox. COVID is a re-emerged disease, I clearly explained to you. Nipah, for example, initially it was reported in Malaysia, but afterwards in Malaysia, the disease was subsided. But other parts of the country, particularly in India, initially it is in West Bengal and northeast part and Bangladesh, but now it is more in Kerala part, it's re-emerging. Similarly, malaria. So these diseases are all re-emerging diseases for me. Malaria, for example, we know Plasmodium vivax, Plasmodium falciparum, but Plasmodium novel is a emerged disease. But of late, we are getting the cases of resistance malaria and re-emerging. They are subsiding and re-emerging. That's happening now. So this is the definitions we need to know. Emerging disease means first time you are encountering or the number starts suddenly going up. Re-emerging disease, the disease was existing for quite some time, then it subsided for quite some time and again coming back. That's most important. So if you know the definition, that is very vital for you. And if you see the literature, if you see the whole map, almost any diseases you can put it, that diseases are keep emerging and keep re-emerging. That's most important thing. That is why we are having a sessions today. Keep on coming back, and subsiding and coming back. This is most important. Very few diseases are shown in a minute now eradicated. Otherwise, most of the diseases are either subsiding and again coming back. That's more important. That's why I included one term called subsiding diseases in this presentation now. Why infections are emerging and re-emerging? Yes, this is a nature's Darwin's theory. The fittest need to survive. If somebody want to be eradicated or somebody want to be eliminated, they try to resist. They try to resist the eradications and eliminations. For example, these are all the diseases keep on happening. For example, the Spanish flu, everybody know 1918. This is a big pandemic. Afterwards, it subsided. Afterwards, subsided and re-emerged in 1950s, again in 1970s, again in 2009. Then 2009 onwards, it keep on persisting, but in a low number. Every year, the numbers can go up and coming down. This is what happening to the influenza. Similarly, the COVID is also going to behave. That's what the thought process is going on. I'll come back and explain what are the diseases has been subsided now. But why we need to discuss? The cost is a huge cost. Whenever the disease is emerging, the amount of prevention, amount of the research, and amount of the suffering is more. The cost is a huge amount. If, for example, the COVID-19 pandemic end up with almost 8.1 to $15.8 trillion we spent for COVID pandemic to control. The amount of lockdown we initiated, amount of vaccines and amount of the treatment and hospitalizations and death. In fact, the death number is a bit less only we are seeing, but now the new figures is going up. So if we calculate the new figures, the cost can go further up. So the cost we paid huge for the pandemic diseases. So this is a death toll I'm talking about. But now if I put this death toll was prepared in 2022, 2023. If I put the death toll of a COVID based upon the latest literatures, it is definitely much more. So the impact is more. Emerging diseases and re-emerging diseases, the impact is more, not only with the cost, but also the number of lives we lost because of emerging and re-emerging. Then people ask why the diseases are emerging and re-emerging. A lot of things is coming to play. The first and foremost things is called climate change. Now they put most of the things as a climate change as a reason. Second thing, we started invading new places. We are exploring the new things and our behavior is also changed. So these are all the reasons for the diseases coming back and re-emerging because we go close to the forest areas and deforestations and everything we are doing it now. So the diseases need to emerge and re-emerge basically because of the climate and because so many factors there. But important thing is the climate and the human behavior. This most important thing for re-emergence. So can you name any diseases that is subsided? I keep on telling about it. A lot of diseases are subsiding and coming back. For example, Mpox, influenza. Influenza subsided almost 30, 40 years in 1918, first pandemic, till 1956 or 1955, 56, again in 1976, again in 2009. So it subsided completely and again coming back. So can you say one diseases is completely subsided or eradicated there? Yes. This is called smallpox. So far, touch wood, but couple of lab reported cases has been there, but usually smallpox has been subsided. Very good vaccination is available. Very good vaccination is available, and vaccination is taken universally. That is why we can identify the person's age by seeing the left upper hand in India. If anybody has got a big star on the left upper hand, then we can call the person has got born before 1980. So because of the impact of the vaccination, this diseases has been eradicated. And similarly, for example, rubella. Yes, even though country like India, we still report rubella, but fortunately, developed country like US, the rubella is almost eradicated for them. But unfortunately, the US is missing the problem of measles. Now the measles has started re-emerging. This is a big outbreak is going in the measles in US. So the measles has re-emerged in US, even though because of the good vaccination drive, they almost verge of eradications or elimination. But unfortunately, it is coming back because of the poor vaccinations that have taken recent times. Then polio. For example, India is verge of eliminating this polio. For example, because of the annual program for vaccination, the pulse polio campaign are almost eliminated. For example, only 4 countries are reporting polio, except last year the small outbreak of Meghalaya that is doubtful there, but not at proved. But apart from the thing, almost eliminating stage polio has come. Why? Because of the regular vaccination drive. But countries like Pakistan, Afghanistan, and African countries, if you want to travel, you need to take polio as a travel vaccines for Indians. If you are traveling African countries, if you are traveling Pakistan or Afghanistan or Kenya, we need to take polio as a travel vaccination. Because of the vaccination, this is a verge of eliminations. And similarly, for example, 1983 to 2004, I can put it HIV. HIV is a new disease emerged in 1983. That's a new emerging diseases in 1983, but it's not re-emerging. It's present throughout the course. Only thing the disease starts subsiding. The disease starts subsiding. A lot of PCP pneumonia, a lot of opportunistic infections. I'll come back and tell what is my experiences with this HIV. So this is a major epidemic or major disease emerged in 1980s. This is a major disease emerged in 1980s. And for example, lot of things. The treatment has changed. When I started practicing my ID career, we used to give 78 tablets. For example, the protease inhibitor, the Indinava regimens, Sakinava regimens has got a big pill burden. Then came with the toxic medications like Stavudin, Diagnosin, then came Zerovudin. So a lot of things has been subsided in the management of HIV. Now HIV entered the era of, even though it's not re-emerged, but it entered the new era of HIV, how to manage. I'll come back and tell what happened to HIV. Couple of cases has been cured, but it's a very tedious process. So for example, now the concept is emerged is you for you. What is you for you? When the disease was not detected or undetected in the blood, it is not going to transmit it to the partner. That is why we want to diagnose this disease early and we want to put the persons on treatment early. So this is the impact of putting a good treatment, identifying a good treatment, how to eradicate or how to eliminate the disease is finding a good treatment. Without vaccines also, mostly the diseases is eradicated. Whatever diseases I talked about it, like smallpox, rubella, polio, all are eradicated not because of the treatment, because of the vaccinations. But this disease has come down drastically because of the good treatment modality. There is no vaccines available, but with a good treatment modality, this disease is very much under control, very much under control. Why? We need to identify the persons early. We need to put him on the persons on treatment. Yes, we can eliminate the disease by identifying more people and follow this rule. All diseases should be identified, and all persons identified should start an appropriate therapy. That's most important thing. So this is what I'm telling there. Previously, we used to have a toxic regimen. For example, the nevirapine and efavirenz, the NNRTI, then caused severe Stevens-Johnson syndrome. This man I saw in 2004, way back in 2004, started with the nevirapine, started developing a mild rash. One day, the Friday evening, he started developing mild rash. We thought some mild itching or something. Give some anti-allergic and went back. Next day, Saturday evening, it developed. Sunday, and again, the duty medical resident again noted and given some other anti-allergic medications. Monday, full-blown Stevens-Johnson syndrome. Just 2 doses of nevirapine, Stevens-Johnson syndrome. He suffered like anything and ultimately lost the life. And similarly, the skin and bone, what we used to see in 2002, 2003, and 2004, but now in 2025, the problem is what is subsided. Almost I can say the wasting disease has subsided. What is emerged or re-emerged for me is obesity in HIV patients. All the ART medications causes a lot of side effects, cardiovascular side effects, as well as dyslipidemia along with obesity. So obesity is coming up in a big way. So this is a famous word for HIV. Those who visited Tamram, one of the major centers in 2004, we started providing almost all sorts of opportunistic infections, wasting, thinning. Any way to label this word contain that one. For example, PCP, that point of called PCP, not PJP, cytomegalovirus. The person has got cytomegalovirus, PCP, toxoplasma, anything you can label, cryptococcus, loaded in 2002 and 2004. But in 2025, almost all the opportunistic infections for me, all the opportunistic infections has been subsided. Why? Initially, when I started the patients on my first patients I started on ART, the CD4 count was 0. Almost 200 hot patients we started with a CD4 count of 0. We prioritized because the availability of medication at that point on was very limited and it just came into the Indian market. So we started using people with 0 to 25 prioritized. In the 0 to 25, I started the CD4 count of 0. That's the state I started with the patients on ART medications. And the guidelines was start ART medications and the CD4 count is less than 200. But now the guidelines, any CD4 count I need to start. So this is how the diseases has been re-emerging or the treatment modalities are changing. This is the treatment modalities are changing with the new knowledge, with the new information. That is the basic idea, how the infectious diseases, the pattern has been changing, we need to remember. So the disease has entirely changed. When I started practicing 2.5 decades back, what I did and what I'm doing is entirely different now. Then people know this is one of the biggest strategy to identify the patients. Anybody want to do for HIV testing, they need to go to the ICTC center, counseling center, because this is very, very, very stigmatizing disease. They want to provide counseling. They want to provide good counseling before doing the testing. That's what happening. This was happening 10 years before. But what happened? This is a paper we wrote. This is a paper. Nowadays, many patients come to the hospital. Right now, good treatment modality available. Once you put the patients on treatment, he's not going to transmit the disease to the other person. He's not going to transmit the disease to the other person. So what we need to do when a person comes to your hospitals, you need to get an informed consent saying that you have come to the hospital, for example, some other disease, and this is an opportunity I can check for HIV. I'm not judging you. I'm not judging you got any risk factors for HIV. No. You came to the hospital, good treatment modality, linking services are available. If I can do the test for example, sugar, BP testing or cholesterol testings or lipids or something, I do it, fine. In addition to the test, what you required for primary disease, in addition, I do the HIV testing. This is called opt-out model. We can give the option to the persons whether they can opt in or opt out. The person says, yes, I can go and undergo the test for HIV, that's fine. The patient says, I don't want HIV test, we stop the testing for the people. So almost 200 odd people we did the thing. 200 odd people initially, then we expanded the testing to almost 1,500 people there. Here we can find out more people tested positive. Almost 13 new cases were identified. The person has got no clue. He came for some other diseases. We applied the opt-in and opt-out strategy. Most of the people agreed for opting in. Very few people only refused to undergo testing. And people, when we tested for 1,500 people, almost 13 people has tested positive. This paper was presented in IDSA. In fact, won the award for best paper in HIV research paper in 2011, 2012, way back. So this is a new strategy we are adopting now. No more ICTC. We can go with an informed consents and giving the option to the patient to choose whether I want to do testing or whether I don't want to do the testing. So not only the diagnosis, not the diagnostic modality is also changing. Some of the concepts like counseling, integrated counseling and testing centers slowly given up, and they are moving forward to other ways of testing also. And similarly, what is other mode I clearly told, the wasting diseases, lipoatrophy. Lipoatrophy, particularly the older medications can cause not only the disease, but older medications. Like the causes like a lipodystrophy and lipoatrophy. But what the medications I'm using is, it's not causing lipoatrophy or lipodystrophy. In contraindication, it causes more of obesity. That's what's happening now. The regimen, what I'm using it now. Previously, I told this many tablets I need to give for HIV. Now, one pill that contains three medications. So the treatment is also changed. What has gone up? For example, the old concepts are giving multiple drugs gone. What is coming up? Only one drug that contains one tablet that contains three medications. That's a concept is emerging now. So these are all things, new things for you. And similarly, what is re-emerging? Yes, dengue is re-emerging. Everybody knows that dengue comes in and the pattern, seasonal pattern is happening. Throughout the year, it's happening cases, but again, some years the cases numbers can go up, complications cases, atypical manifestations happening with the dengue. A lot of things is happening with the dengue now. Similarly, chikungunya, not only dengue, chikungunya also behaving. Compared to dengue, chikungunya, in fact, couple of years the chikungunya was not reported. For example, in 2007, we faced a major outbreak. Then till 2013, 2014, there's no major cases. Then again 2013, 2014, of late the last couple of years again we started seeing chikungunya. It starts behaving like a dengue. Sporadic cases keep on happening and small surges is happening with the chikungunya. So all vector-borne diseases, the tendency to re-emerge is most likely depends upon the vector populations, depending upon the climate changes what I discussed. As far as India is concerned, the main problem is Nipah. Previously, it was restricted to the Bangladesh and West Bengal side, but right now Kerala is facing on and off. Kerala is facing the problem of on and off. Nipah cases also. Not only Nipah emerging in Kerala to get a good updates. What is happening, what is emerging, and what is re-emerging is most important for you. And similarly, Zika. Zika was previously an African problem, Brazil problem. South American country of Brazil is a problem. Then it moved to the Africa, but we are seeing Zika cases. Last time when Guillain-Barré syndrome happening in the Pune, people thought Campylobacter, but people also thought Zika outbreaks is also overlapping. So Zika, whenever you think a patient has got dengue, or when the person has got dengue test is negative, always think when to suspect Zika in your practice. When you think the person has got classic dengue presentations, the platelet count is not too low, but the skin rash is more. When you think the person has got dengue-like presentations, and you're consistently doing your serological test, for example, NS1 or IgM, or even PCR, and the PCR is also negative, your clinical thought process is an acute viral fever, probably dengue or chikungunya-like presentations. Both dengue and chikungunya has been ruled out. Chikungunya more of polyarthralgia, but Zika has got more of subconjunctival conditions along with skin rash presentation. That is classic. Particularly pregnant women, you need to worry about it because it can cause microcephaly. So whenever you encounter pregnant women with microcephaly, or when a person has got fever and rash, and the dengue test and chikungunya test came back negative, thinking of Zika, that's most important thing. Nipah, yes, again, whenever the person is present with meningoencephalitis, typical workup is negative, the disease is progression, and the family members got involved, think of Nika. And again, exposure, particularly that's most important thing, the bad exposures. Or the person should consume the sap, you need to drink, the palm sap you need to drink. So think about it. The history taking is very vital to find out the emerging diseases and re-emerging diseases. That is very need of our. So we need to check proper history taking is going to give the clue to me there. Then we know SARS, then we need to know the SARS-CoV. The SARS-CoV is an initial epidemic happened in 2001 to 2002. That's not SARS-CoV-2, SARS-CoV-1 has happened. Then came MERS. MERS-CoV came in 2011 to 2012, particularly in the Middle East. This happened in Middle East country, and the death modality is more compared to the SARS-CoV-1. SARS-CoV emerged in China and Hong Kong. But what happened in 2019 and 2020, we know people start wearing this type of jumpsuits and people start screaming for everybody and shooting with a thermal gun. But what is subsided now in 2025, nobody is wearing these jumpsuits. One, people are not shooting with the gun. That's most important thing. In fact, these publications we produced during 2020 epidemic, we started screening almost 45,000 healthcare workers because during the time of 2020, all persons entering the healthcare or all persons entering any organizations, their forehead is shooted with the thermometer. So the thermometer never picked up. Almost 45,000 encounters of healthcare workers between 2020 March and 2020 November we audited. Almost 45,000 encounters for healthcare workers because easy to follow. The people are working in the same institutions. We can track the persons, what happened to the persons. We track the healthcare workers instead of patients. Or the 45,000 encounters, what we encountered. So none of the time the thermometer picked up. But during the time, almost 68 to 70 people are admitted with the COVID. Unfortunately, the COVID serology test came in the month of October, November 2020. And we did the serological testing because the vaccines was not available in 2020. Vaccines came into the market 2021 January. 2020 October, November, the serological test, antibody test came into the market. Almost 500 hard healthcare workers willing to provide a sample to check whether they got COVID or not. Almost 540 people tested positive. Out of this, only 68 admissions happened. So that means the thermometer does not pick up any cases of the COVID. So this type of screening is not required. So the emerging and re-emerging diseases gives a lot of ideas and a lot of ways we can know what's good for prevention is what is not good for interventions also. We know during the COVID time, a lot of RCTs, a lot of new modalities of conducting trials has been emerged. And we fast track a lot of therapeutics for COVID time. So that's what happened at that point of time. And this one modality. So in 2025, what we should not do, the forehead thermal screening is outdated. The data is there, 45,000 screening of healthcare workers, zero pickup. Then RCTs. For example, that too, randomized control trial happened in a different way compared to what randomized control trial happened otherwise. All data start emerging, randomized trials start emerging, and start people are using to their randomized control trial testing they did it now. And what happened? People start using that azithromycin and doxycycline in the day of March 2020. But unfortunately, good data came little late from June 2020 onwards. For example, azithromycin has got no role. The NEJM publications happened in June 2020. But most of the guidelines till 2021, they not changed. For example, Indian guidelines, if you see 2021, guidelines itself is not changed. And healthcare workers, they want to use all patients. In fact, all healthcare workers tested positive, first thing they take azithromycin. Similarly, hydroxychloroquine and chloroquine was fasting for September, October 2020. Then azithromycin, doxycycline then started in 2021. And guidelines start removing this azithromycin. International guidelines removed azithro and doxy little early. But Indian guidelines took time to remove this one. But Indian clinicians still using azithromycin and doxycycline. So we need to know when a disease is emerging and a disease is re-emerging, we need to know not only which disease is emerging, which disease is subsiding, and which is re-emerging. During the re-emergence, what is the data? We need to closely monitor it and what is happening to the particular disease. What treatment modality is outdated? what treatment modalities come into the place, we need to know. These things has got no clue because 2020 hit a pandemic, lockdown initiated, no testing modality initially, very few testing centers, very few treatment, no idea of how to treat this disease, lot of things. But once it got a new information in 2020 June onwards, we start streamlining our protocols and strengthening the protocols. But unfortunately, the clinicians are not updating the protocols. That is one of the opportunity we need to know this type of diseases now. For example, what is subsiding now? Molnupiravir is no more available, and the data for molnupiravir is also not that great. Yes, molnupiravir only selected conditions we can use it. It has got other contraindications like pregnancy and everything. Similarly, people start using favipiravir. Yes, favipiravir is gone. Remdesivir is always a tricky one there, but yes, still remdesivir we can use it. But what came in the market like Nirmalpravir, it's called US, it's called Paxlovid, but in India it's called Nirmacam. But right now it's not available. But this has got emerging in last couple of years as a treatment modality for COVID. So we need to follow closely the treatment modalities also to find out what is coming and what is going on. That's more important for you. And similarly, what emerged in 2021? COVID-associated mucormycosis, COVID-associated aspergillosis. Mucormycosis is known disease. Mucormycosis is a known disease, but COVID-associated mucormycosis is re-emerged in 2021. That's new one. But mucor is existing for quite some time. Similarly, aspergillosis, everybody knows it. It's existing for quite some time. COVID-associated aspergillosis emerged in 2021 and 2022. Why? Because of rampant use of steroids, rampant modality of natural forms of treatment, and lot of other without evidence proof treatment we used it, and we suffered. Even young people suffered, old people suffered, a lot of people lost eye vision, some other people lost their life also. So this is COVID associated mucor is re-emerged. So re-emerged in 2021. Similarly, what is emerged after 2021? This is a new entity. Long COVID is not existed. Even COVID is existing in 2020. COVID-associated mucor re-emerged in 2021. But what is emerged? What is emerged? It's not re-emerged because long COVID, nobody knows in 2020. Once a person recovers from COVID, they are very happy. I'm recovered from COVID, I'm survived. But a lot of long-term consequences of the COVID, that point of time in 2020, nobody recognized. But a lot of people start complaining, I'm not able to think clearly. I'm not able to recollect. My memory was very sharp before COVID, but now I'm struggling to find the name of the persons, name of the things what I do. Similarly, people's taste and smell still not coming back. People still have shortness of breath while climbing stairs. Previously, I used to climb two stairs without any difficulty, but now I'm finding difficulty. So the long COVID is a new entity that emerged in 2021, 2022. So this is a disease emerged in 2021 and 2022. But same time, COVID associated mucor re-emerged. So we need to know a lot of definition system. What is long COVID? What is chronic COVID? What is post-COVID? A lot of new terminology has re-emerged in 2021. These are the diseases we need to recognize and find out. Then one more thing is subsiding. What is subsiding? I'll come back to this talk a little bit later point of it. What about the vaccinations? I talked about the diagnostic modalities, screening modalities, diseases, how it emerge and re-emerge. And when talking about how the vaccinations also re-emerging, what is the concept is coming back in my COVID presentation shortly there. So similarly, the variants, for example, initial variant was a wild type of variant, Wuhan type. Then came alpha, then came beta, gamma, delta. Delta is a major one, produces a devastating problem in 2021. Almost all the hospitals, almost countries devoid of oxygen and essential medications in 2021, and Delta hit the Indian market, Indian country. So these viruses are gone now. There is no more Wuhan type. There is no more alpha, beta, gamma, delta, even Omicron. Previously in 2023, 2022 January, Omicron came, and subsequent lineages. The final one was JN1 was 2024 was circulating, but now even JN1 was sublineages have started emerging from the JN1. That's what emerging now in JN1 also. So these things have gone now or subsiding now. And what is re-emerges? New variant is re-emerged now. So coming back to this new variant, I'll come back and do the presentations. 75-year-old male. So I want the participants. I just give only a couple of cases initially, but put in a couple of cases now. 75 diabetic coronary artery disease, recent CABG, fever of 2 days durations. We got body pain, hip pain, sore throat, running nose. No travel, no sick contact. On examinations, febrile, weak, stable vitals. Respiratory system is clear. Saturation is 95%. Thus, these patients have COVID-19. How many say, yes, this patient has got COVID? No, maybe test or start remdesivir. What will you do now? I'll just wait for a minute because I want to see the responses in the chat. So for people who want to get the happenings, I like to see. So people want to test. 3 and 4 is the unanimous choice. People doesn't want to say this patient has got COVID or no, maybe, or test. They don't want to say clinical diagnosis. In 2020 March, this question has been asked people to say COVID, but in 2025, people are struggling to say, I need to test to prove it. This is not COVID. Why people's thought process has changed? Because influenza, RSV, still existing and still circulating along with the COVID. So this cannot be COVID alone. Maybe other diseases also can coexisting. Yes, COVID numbers has come up, but it's not a huge number. I've started seeing COVID cases, but not in a huge number what I saw in 2020. Other diseases like H1N1 and RSV diseases is still happening now. That's a good thought process. So this person has got no travel, no sick contact. How they got COVID? Suppose if the person has got COVID-10 positive, how the person has got COVID? Any thought process? I can give you any choices. Just go ahead and put it in the chat box so that we can discuss. How the person? Diabetic, coronary heart disease, recent CABG. CABG happened 1 month back, not recent one. 1 month back. But now it's happening. So 4 might. So person got discharged 1 month back. He got no sick contact. People are talking about format, people are talking about contact. There's no sick contact. Nobody in the family, all the family members are healthy. Any positives you can consider? So always in infectious diseases, we need to find out what is the exposure, how the person is exposed. Diabetes mellitus, hospital acquired maybe, but 1 month back. So we need to know what is the last visit. The person underwent CABG 1 month back, but the person visited the cardiothoracic surgeon and cardiologist 3 days back. He spent sufficient time in the hospitals. He underwent ECG, echocardiogram, and evaluations by the cardiologist and cardiothoracic surgeon. He spent almost 2 to 2.5 hours in the hospital without wearing a mask. One. That's the most common position we are thinking in this case. And second thing, this person finally turned to be positive for COVID. Second thing, this person has got some of the family members may be asymptomatic. We may be carrying the viruses without any major symptoms, and it may be transmitted, even though there is no sick contact. So the person may be asymptomatic in the family. He will have transmitted the diseases. These are all the positives we can consider if the person turned to be COVID positive. Okay. So why this re-emergence diseases of COVID? People are talking about it. For example, all newspapers daily start showing India numbers gone up to 4,000, 5,000, and a lot of newspapers and a lot of social media is very active. Compared to the print media, social media is very active. This is a 2023, my last presentations of COVID I made in 2023. Afterwards, I never made any presentations on COVID in 2024 and 2025 till May 2025. I didn't have any presentations. So why? Is there any room for complacency? In 2023, we asked, COVID came, COVID gone. Is there any complacency? We can forget about the COVID. What we need to do in 2023? This is the questions I asked in 2023. This is a presentation slide I took from my 2023 presentations. Keep on changing. Omicron came. Everybody hit. Most of the people, almost 70% of Indian populations completed a decent vaccinations. What will happen to the COVID in the future? In 2023, everybody was thinking about it, discussing about it. But what happened in 2025? New variant. But what is this new variant? I'll come back and show the new variant. This is called Nimbus. So easy to remember compared to NB 1.8.1 is difficult. This is one of the JN variant sublineage. It has got couple more mutations in the surface protein. Couple more mutations in the surface protein. So it got 2 or 3 new mutations. As a result, what happened? It is highly contagious. Go and stick to your AC receptors very well. But it evade your immune system also. People said, I had COVID in the past. I vaccinated 2 doses, 3 doses. I vaccinated. Despite your vaccinations, despite your previous COVID infections, it can evade your immune system. One, it has got high efficacy to attach to the AC receptor. That's most important thing. Because of the mutations it's got from JN1 lineage, but severity so far I'll show what happened to this variant shortly now. So this is a WHO data I taken from the month of May. What is interesting, focus the Southeast Asia. In April, what is the data of Southeast Asia? 55 cases reported. See the left-hand corner in 55 cases reported in Asia, not in India. I'm talking about Asia. But what happened in the month of May till 11th of May? Almost 70,000 of cases has been reported. So the numbers has gone up in Asian country, particularly Hong Kong, China, Singapore, Thailand. These are the cases as reported maximum in May part. Then see the next part. How many hospitalizations? If you see the WHO data, this is not taken from any local data. I have taken from the WHO. The WHO says almost 65,000 to 66,000 hospitalizations. Whether because of the panic or because of the thing, we do not know. That point of time, India just starts seeing the cases, but almost 65,000 hospitalizations. But majority of the patients are mild. Why I'm saying mild? See the next bar. Next bar, critical care admissions. Critical care admission, there is no data. Almost there's no significant serious admissions in critical care unit. And the last one is also death. The death has been reported, but not in huge number, what we saw in 2020. So what happened to the COVID in 2025? More number of cases is infected as per the WHO data. And second thing, couple of hospitalizations area. Because of the fear of minimal oxygen support, we do not know. But what is good news? The critical care admissions and death is not happening more. That's a good news as far as COVID-19 Nimbus variety is concerned right now. The Nimbus so far does not major havoc, but deaths are still happening, but not in a huge number. Then this is a data I taken from the Indian government. Indian government, what is more important? We see almost 4,000 odd cases. This data up to June 3rd. They show almost 4,000 odd cases. And again, if you see death is happening every day, 4 to 5 people are losing, and number of cases testing positive also, there's 100 odd cases there. So still for 4,000 odd cases, India lost almost 30 to 50 deaths happening. This is only reported death. Previously, first week or first 10 days, people still not reported COVID deaths. But if we start reporting COVID death, we need to know the numbers. But so far, with the data, what I'm saying, so this is the data I got from yesterday. Yesterday, how much? 5,364 active cases is present. And if you see, 5,300 cases is there. But death, if you see the 55 deaths. So hardly the death rate is 1 to 2% only still going on. It's not a major amount of death is happening. So we need to know what is happening. Then we need to know about the variants. So these are all the terms. For example, the WHO essentially ran out of naming the viruses. It started with alpha, beta, gamma, delta, then went up to almost all the Greek letters like Q, Omicron, Nu, everything they lot in. Then finally, this one is called Nimbus. The Nimbus means cloudy. Cloudy means the presentations, how it's going to behave, we do not know. So this is called Nimbus. So new variety that's called 1.8.1. That's what's happening right now. So we are going to monitor closely. So far, more cases are infected. For example, similar to our mobile phone versions only there. The surface coating keep on changing. Otherwise, the virus is same only to me. Then how the virus is behaving? What is the new in symptoms? As far as the new in symptoms, typical presentations, fever, cough, sore throat, and lack of taste and lack of smell still going around. But more amount of myalgia is happening. Sudden onset of headache, sudden onset of back pain, particularly the low back ache or pelvic region, the people are complaining severe backache. And couple more cases of diarrhea. Diarrhea is one of the common presentations we encounter. So this Nimbus variety, what is the new year? People got fever, cough, and sore throat. In addition to the fever, cough, sore throat, shortness of breath, lack of taste and lack of smell is going around. Myalgia is existing more cases. Headache and body pain, particularly for the first 1 or 2 days, the headache and body pain is terrible. Diarrhea is happening. That is also new to this variety. Previously also we encountered diarrhea, but this variety again showing more of diarrhea also. We need to keep in mind these are the symptoms to think about it when to think over in the practice. But unfortunately the problem is it mimics other viruses. That's why people want to do the test rather than say clinically I'm confident this is COVID. They can't say. In 2020, anybody presents with fever, cough, sore throat, lack of taste and lack of smell, there is no need to test also. But in 2025, still influenza can behave this way and other respiratory viruses. Mycoplasma won't behave this way. The terrible cough of Mycoplasma is persistent. But here, the presentation between influenza and COVID is very difficult. In RSV also confuses particularly in pediatric populations. So it's a bit difficult to say this person has got H1N1, this person has got COVID or RSV. But what we notice this variety compared to other two things, but if you see the literature, myalgia, back pain, yes, H1N1 also can cause. But compared to the H1N1, COVID has got slight more headache, more body pain and back pain. And similarly, diarrhea can happen with H1N1, but we are seeing slightly more with COVID compared to H1N1. So this is a trend we are noticing. In the last couple of weeks, we are seeing this is a trend I'm seeing there. So coming back, how many says yes? Now I told influenza is also existing and H1N1 is existing, RSV is existing. So how many say yes? Does these patients have severe COVID or mild COVID? So I told the person finally tested positive. So the person is tested positive. What do you think? The person has got mild COVID or severe COVID? Go ahead and vote. Just what is your responses here? People say this is mild. Okay. People say 4. They want to do some D-dimer. They want to go back to the 2020 mode. Want to do the PT test. They want to do the D-dimer in the previous day. What we used to do, they want to do it right now. Okay. So usually we need to know the severity. So first thing in infectious diseases, does this patient have COVID or does this patient have got infections? If it is infection, does this patient has got COVID? I told them the person has got fever, cough, sore throat, lack of taste, lack of smell. In addition, headache, body pain, myalgia, along with loose stools, along with sick contact, that is more important. Travel, hospital visits, we need to keep in mind. The next thing is what is the severity? Whether the person has got mild, moderate, severe or critical. That's most important thing. Mild, as you know, only upper respiratory tract symptoms, fever, cough, and sore throat. There is no shortness of breath, no pneumonia. Moderate, the person has got pneumonia symptoms, but the oxygen requirement is not great, and saturation is vary between 90 to 94. But what is severe? When the oxygen requirement is more, the person needing tachypnea, very high amount of oxygen, is called severe. Critical means organ dysfunctions, particularly the persons on ventilator or ECMO or vasopressors. Nowadays, people are talking about seizures also, particularly status abilities, but very small number, but don't confuse with the thing. So we need to know the staging. So first thing ask, does this patient has got infections, particularly does this patient has got COVID? Second thing, does this patient has got severe infections or mild infections? That we need to remember. How to severity, this is a severity assessment, we need to put it now. What I do in my practice, when we encounter the patients, apart from the severity, mild, moderate, severe, and critical, we need to know, predict which patients I need to hospitalize, which patients I need to start intervening. So this is a beautiful graph, I can put it right now. We need to ask two things because this disease is re-emerging disease, not an emerging disease, it's a re-emerging disease. That means I need to ask past COVID infection, whether the person has got COVID in the past or not, one. Or the person is vaccinated or not. If the person is vaccinated 2 or 3 doses, most of the people completed the vaccinations up to 2022. 2021 it started. Some people are late uptaker. They finished in 2022. After 2023, almost the vaccine is gone. Only few strains has come, but now that is nothing is available in 2024 late part. So what we need to know whether the person has got previously infected or not, and whether the person is carrying a risk factors or not. That's most important. So apart from the severity assessment, whether the person has got mild COVID, showing only upper respiratory tract symptoms, moderate COVID, showing a pneumonia symptoms with very minimal oxygen, severe with more oxygen requirement, or critical requiring organ dysfunction support. So apart from that thing, I need to know what is the risk factors. What are the risk factors the person is carrying? What is the past infections, past vaccinations, then age. If you see anybody crossing more than 50 or 60, the chances of complications is always high. So that's why the red column is always there for people above 60 or 65. On the other hand, the person is young, previously vaccinated, previously had COVID, no comorbid conditions, particularly this is a Omicron variant, they are going to behave without any major problem, mild. But long COVID, I need to wait and watch because all diseases, whether it's a Delta or Omicron, it causes a long COVID. That's a big problem. That's what people are thinking about it. So, but for a person, a young person, previously COVID, vaccinated, and the person has got no comorbid conditions and age is less than 50 or less than 60, you can put it, the chances of going for a complications or hospitalization is bit less. So the treatment decision depends upon this graph only, you can put it right now. So this is a graph, very important graph for you. Then risk factors, if you see and see, almost all the risk factors is mentioned. But how to remember, except systemic hypertension, any diseases you can label. For example, in brain, the person has got stroke, the person has got dementia, the person has got Parkinson's, everything has a chances of severity is very high. Heart, for example, not only myocardial infarctions, myocardiopathies, as well as congestive heart failure, the risk is very high. For diabetic, both type 1 and type 2, yes. Respiratory system, COPD, handling LDSS. Kidney again, CKD and other coronary diseases, yes. Immunosuppression, yes. So we can say, instead of looking at the risk factors, except the person's got systemic hypertension and no other risk factors, the person does not have a risk factor. We need to think when the person is carrying 2 or 3 risk factors, the chances of going for a complication is very high. Only one risk factor, the chances are a bit low. So how to stratify your management? So we need to know whether past COVID, past vaccinations, and risk factors, 2 or 3 risk factors, the risk is very high. Age more than 65, the risk is very high. This is what we need to do the risk assessment. the next step in infectious diseases. First, does this patient has got COVID? Second, does this patient chances of developing severe? Even though the presentation may be mild, but the chances of severe, we need to think in mind. Then third thing is what I'm going to do, what test I want to do now. Because most of the people previously they do only PCR in 2020. I want to see the responses, what test you want to do in 2025. Whether you want to do within the PCR or whether you want to do something else. People say PCR only. COVID plus combination people are trying them. They want to do the combination modality, not only PCR, because I told H1N1, RSV is circulating. So if we do the triple panel, the last one, the multiplex PCR is the 15 viruses, including mycoplasma, you can able to pick it up. People say Travis panel, they're talking about it. That's good thing. Okay. So this is the basic of viruses. We know everybody knows it. And this graph is very vital. What is the differences between the antigen test and PCR? That's what we need to do. Antigen test you can keep in a clinic. You can do a point of care. PCR, yes, small PCRs are available, but that's costly. People are not doing it. Usually they sent out test. So what we need to do, what is the differences between the PCR? PCR came positive little early, but it remained positive for weeks also. Antigen test take 1 or 2 days later compared to the PCR, but it disappear a little faster. So if you want to find out whether the person is infectious after day 5, day 7, they're worried about I just go and mingle with my family or not. We can do the rat. That's most important thing. That's most important thing. On the other hand, PCR can remain positive. Previously in 2020, we used to remember 2 PCR negative only can discharge the patients. But the concept is gone because this PCR we know the viral PCR can remain positive for 2 to 3 weeks also. This is useless test. So if you want to remove the infection control point, either time dependent or depends upon the rat test that has got. But the limitations of the rat test, it has got very good specificity. The sensitivity is nothing, keep in mind, that's more important thing. Then what is the nucleic acid amplification test? That's a standard test. Antigen based, this is a quick test, you can do at point of care. Serology, but now it's very limited role for me. Serology has got very limited role for me. We can find out whether the person is previously infected or vaccinated, got immunity by doing couple of antibody tests. For example, the antibody to N antigen says the person has got previously infected, but on the other hand, surface antigen present only in the vaccine. So that indicate the person has got vaccine related immunity. So how to interpret the rat test? So the rat test is positive, most likely COVID, because specificity is good. Rat is negative, either the test has got poor sensitivity, missed out the test, or it is not COVID. There are two options. One, it is not COVID, or the test is not picking up. But positive, it is positive. And the advantage is the person clearing. For example, the person has got COVID, cleared. Negative means the person has got viral load has come down. That also can interpret. So positive means most likely COVID. Negative means either the person is not having COVID, or the person is really, so still the rat is missing out, or the person is cleared the viruses also. So these are all the possibilities. So don't say the person has got rat negative, I ruled out COVID. That is a myth. So that's a myth. Antibody test I told. N antibody indicates infections. S antibody indicates previous vaccination is possible, but the tests are not available now. Then what variant is now? Now the variant is called Nimbus. It's called 1.8.1. That's more important for us. Then radiological pattern remains same. What happened in 2020 and 2025, but the severity we are not seeing what we used to see in 2020 and not seeing that bad severity. For example, the CT scan of almost 23 out of 25 or 20 out of 25, they put a scoring system that's not existing now. Only peripheral ground glass opacities, yes, we are seeing there. So peripheral opacities we are seeing, ground glass opacity, interstitial lung disease pattern, we are seeing it, but the severity is not that bad of 2020. Treatment modality, I told previously, there is no more azithromycin, doxycycline, and even molnupiravir is not available. Even nirmaltravir, the Nirmacom, that is also not available. Please all mute yourself. Please, Dinesh Shani, please mute yourself. Dr. Dinesh, you told us standard instruction, please mute. Dr. Dinesh, mute. So we need to know the what treatment is there right now. Remdesivir. Remdesivir is available right now, but unfortunately, some of the companies has got short expiry. August or somebody has got December expiry, but will come back. So if the person has got mild disease, most of the time, when the person is young, previously had COVID vaccinations, previously had COVID infections, no comorbid, less than 65 years, there's no treatment required. On the other hand, mild disease, for example, the person has got upper respiratory tract symptoms, yearly presentations, the person presents to you within 3 to 5 days. As per the guidelines, up to 7 days we can give remdesivir, but I consider early presentations less than 3 or maximum less than 5 days durations. The person is a comorbid conditions. I told the risk factors, what are 2 risk factors for people above the age of 70. People who got above the age of 70, 2 risk factors, previously no COVID or partial vaccinations, no vaccinations. I can give remdesivir short courses 3 days for the mild disease itself. Moderate diseases, when the person come to the hospitalizations, early disease, for example, up to 7 days, and multiple comorbid conditions, previous vaccination is missing, yes, we need to give remdesivir. And the person requiring more oxygen going to the critical care, late presentation, there is no role for remdesivir, only dexamethasone. Ideal dose is dexamethasone 6 milligram, and the person is severe, not responding, we can double the doses of it. Similarly, the dose of methylprednisolone is 32 milligram, that is equal to dexamethasone 6 milligram. When to give the anticoagulant prophylaxis? Ideally, we need to give the anticoagulant prophylaxis when the person is in hospital, not in the OP. When the person in the hospital, the risk factors for DVT is high or thrombotic tendency is high. People are using indirect subtle group of D-dimer, but when the person has got thrombotic tendency is high, the person in the ward, usually we consider risk of DVT is high, therapeutic anticoagulation. That means 1 mg of your low molecular heparin twice a day. On the other hand, critical care, when the person is admitted very sick, the chances of bleeding is very high. Give prophylactic doses of low molecular weight heparin once a day, 1 milligram per kilogram once a day. When a person has got renal impairment, consider heparin rather than low molecular weight heparin. What about tocilizumab? Tocilizumab, when a person receiving oxygen, person receiving steroid, despite worsening happening, then we can consider tocilizumab. 1 dose is ideal. If the person is still not improving, 1 more dose we can supplement. The person is not affordable for tocilizumab, we can consider baricitinib, but unfortunately the baricitinib causes baricitinib kidney failure. We need to check. Creatinine should be normal, but the duration is 14 days. 10 to 14 days people are using it. Bari is cheaper, but always check creatinine before start using Bari. So these are all the modalities. Right now, what is available in India? Remdesivir is available. Personal Dexa, everybody knows it, and methylprednisolone, low molecular weight heparin, ICU, prophylactic doses. What give therapeutic dose? That's most important. Sorry. So this is again I taken from my 2023 presentations. So I mean, last couple of slides I'm presenting it now. So what will happen to the COVID? I told them in 2020 people are asking what will happen. This is a presentation I made in 2023. What is happening in COVID in 2025? What we faced in 2020 is a huge wave. Are you going to expect similar wave in 2025? Definitely no. Because even though the invasion is very high, attaching to the AC receptors is very high, evading our immune system is very high, but still it is not going to, it's not going to replace, it's not going to replace the previous wave because this is a re-emerging now. Some amount of immunity, some amount of vaccine-related protections can exist. So it's going to happen in a small wave. It is going to behave like an influenza in the future. How the influenza is behaving in 2009, it came in a big pandemic. Then again, it's coming in a small epidemics and endemic. Similarly, it's going to behave this way unless a rapid variant like a Delta type variant, if it is emerges, then only a new pandemic like influenza happened in 2009. That is possible. But next couple of years, this is going to happen in a small way, but the gap between one wave to other wave is small. It's not going to be a major impact. That's what the prediction is going around. Then people talking about the vaccinations. I have not talked about the vaccinations. Right now, there's no vaccinations. Previously, 2 weeks before, you read the 2 weeks before, what is the recommendations for the vaccinations? Everybody is supposed to take the vaccinations. According to the US data, ACIP says everyone every year take vaccinations. But now vaccinations also only for people above the age of 65, people with multiple comorbid conditions. But US FDA recommendations for pregnant women, they are not giving the vaccinations, but we supposed to give pregnant women. Similarly, for healthcare persons, they are not giving it, but we need to give the vaccinations for healthcare program, provided the wave start rising more. So far, the wave number is very less, but once the wave start eating, we need to consider vaccinating people, particularly above the age of 65, comorbid conditions, people pregnant, healthcare worker, we need to vaccinate. So these are all the indications, not everybody. For example, the healthy persons, previous COVID, previous vaccinations, now the guidelines is not required. Most of the country guidelines, somewhat the slide is missing there. So it indicate only people above the age of 65 need to get the vaccinations and people with comorbid healthcare pregnant. But what threshold? Usually at the threshold of 10%, we need to keep it. That's most important. The numbers goes up, then yes, otherwise we don't need for it. So what we need to do? these viruses are going to emerge or re-emerge. We need to have a point of care test, for example, the RAT test for COVID, but we need to know the sensitivity and specificity, how to interpretations. So point of care, cheaper test, it's more important, but good sensitivity and specificity test. Most of our tests have got specificity, but sensitivity is lacking. So we need to create a good test modality. Unless we diagnose, it's a bit difficult to identify which disease is emerging and which disease is re-emerging. It's a bit difficult. So we need to control the pandemic. We need to create a diagnostics. That's most important. The diagnostics should be available at point of care. It should not be to the central lab where I need to send and reports will come back 2 days, 3 days. It's not acceptable to me there. And we need to have multiple levels of preventions and treatment. Not only the vaccinations, I told vaccinations plays big role, but we need to find a good modality of treatment. For example, one of the new entity called when a person is critical, when the person requires ECMO support, vilobelimab, one of the newer monoclonal antibodies is just got just undergoing a trial, off-label indication, so we can enroll the persons on trial. That has shown a good mortality benefit. So when the person has got severe COVID, going to the ICU, going to the ventilator, going to the ECMO support, this molecule called vilobelimab, the paper was published a couple of days back in NEJM. So yes, it has shown only this type of indications, but right now it's not approved by FDA, but we can enroll the persons on trial. So we need to have good treatment modality along with the vaccinations, along with the diagnostics. That is the way forward to stop this type of pandemic rather than relying on only by means of clinical equipment. That's not going to help out. So if you want to stop the emerging and re-emerging diseases, we need to be aware first what is emerging and what is re-emerging by reading the medical literature. One. Secondly, what diagnostics should be available at the point of care. And three, we need to follow the prevention methods if the prevention method is available. Right now, the Covishield and Covaxin is not going to help you out because what is circulating in 2020, the wild type or alpha type is gone. Even delta has got a little bit of protections, but for Omicron variant, the effectiveness is not that great. So we need to find Omicron specific variant. That's why the US recommendations Omicron specific vaccinations, but none of the vaccines is available. One of the Omicron derivative, that's old Omicron derivative vaccines available till 2024, but that is also gone out of the market. So we need to wait and the cases starts emerging and the cases start surging. That point of time, vaccination should be brought back. That's most important. Apart from your mask, but there's no need for thermal screening. It's all gone. So we need to know what modality is working, what modality is not working. It's more important. So to learn more these things, they are coming up. So just screening. The newsletter will come this month. Don't worry about it. It's a long due. It's coming up in a big way. It's coming up there. So just closely monitor the space for newsletter. We are launching this month there. And still not over 11. We are updating this type of modality. We are coming up with new algorithms. For example, what is an algorithm for 2025 for COVID? We are launching in the newsletter what we are going to release this month. So we are launching the new algorithms also coming up. So start engaging with the thing and we'll see. I have not seen any questions because I presented today, so I want to just check what is the questions has been posted now. So we start putting the questions for next 5 minutes and we'll finish by 8:35. I just see. So people want to get reference, also post questions. Any questions? So far, so people only want to, yes. Transmissibility high for this study. Yes, we call the reproduction number. I just did the literature search before coming to this presentations. It comes around 1.3 to 1.5 because it is the spike protein mutations in the spike protein made the virus to evade your immune system and attaches to the ACE2 receptors. So the infectivity is bit high, more than 1 only. The reproducible number is called R0. That is more than 1 for this virus for Omicron variant. That's what the literature suggests, 1.3 to 1.5. N95 mask must or no? Definitely no N95 mask at this point of time. Only people are intubating, people are doing aerosol generating procedures N95 mask. For routine patient care, surgical mask is more than sufficient. There's no need for N95 mask at this point of time. Unless you intubate, unless you do CPR, or unless you do aerosol generating procedures is no. RAT test, what is the sensitivity? The sensitivity varies between the different modalities. 10 to 70% they put. Average it comes around 30 to 40. Depends on what timeline you are testing. We do testing little late. For example, after 5 to 7 days, it remains poor sensitivity. Similarly, on day 1, sometime it may miss out there. Ideal is day 3, day 4. Yes, the sensitivity is around varies between 10 to 70, depending upon what kit you are using and what kit you are using. That's going to decide you there. Which drug you said last time as a trial for severe cases is vilobelimab. This is a monoclonal antibody. If you see the NEJM publications called vilobelimab, VALOBELIMAB, vilobelimab. that has got the role. Is not a really approved drug. Favipiravir used by drug because molnupiravir has got a lot of genetic and mutations, chances of causing problem, particularly pregnant women is contraindicated. So molnupiravir is gone. We are waiting for again the numbers goes up. Maybe the company can drop the nirmatrelvir ritonavir combination. They can come back. So we need to give the remdesivir for elderly with COPD. I told them that's why risk assessment. Not only the elderly, the person has got two risk factors. Elderly means above the age of 65 or 70 are keeping it. The person has got COPD. So two risk factors, previous vaccinations and previous COVID. Previous vaccination is completed 3 doses and COVID is completed. Right now the mild presentations, whether the person can easily follow up in a OP or not. If the person is easily followed, some good family support is there, we can monitor also. Or if the person is worried about it, last time we suffered a lot. We can give the remdesivir short courses, early presentation up to 7 days, but usually for a mild diseases, we can keep less than 5 days. Patient COVID RT-PCR, I'll come back. We'll keep moving there, just come on, because I'm doing today. Yeah. Molnupiravir effective? No. Isolation required if yes, how many days? Yeah, that's a good question there. Previously, the isolation people put 10 days and other thing there. Even for quarantine now, the guideline says usually when the symptom subsides and the fever subsides without paracetamol, 24 hours we wait. Without paracetamol, there's no fever. Symptoms are suspended. Particularly the fever is the main symptom because cough, some amount of cough, some amount of tiredness will persist. Fever subsiding without paracetamol, 24 hours is a timeline. You can move out, but wear mask for next 4 to 5 days. That's more important thing. For example, in hospital cases, when the person's in the ward, we usually keep the persons in the 5 days to isolations. The person requiring high flow oxygens, HFNC or ventilator, we usually keep 10 days. When the person is immunocompromised, ideally we do 2 RAT tests, not PCR. RAT test, if the RAT test is negative, we can remove the persons on isolations. That we can do. So favipiravir will discuss about molnupiravir. Hospitalizations required. Okay, so many days. Hospitalizations only when the person requires oxygen, particularly more amount of oxygen. People with multiple comorbid conditions, yes. Otherwise, please don't hospitalize all patients. What we did in 2020 second part, and don't do it there. Which check is in the last link from within 1 second. If you need to give how long the person should actually answer. Anticoagulant, I told. For a therapeutic anticoagulations, usually in critical care unit, or the person is without any major thrombosis risk factor, the D-dimer value, everything is less. You can give a prophylactic coagulations. That means 1 mg of your enoxaparin subcutaneous once a day. The person is requiring more oxygen. The person is requiring high negative D-dimer values and thrombotic tendency is bit high. You need to give a therapeutic. Therapeutic means prophylactic means prevention. Prevention means once a day. Therapeutic means same dose twice a day. Anticoagulants, which one is better? Please share, not accept. Patient is please share PPT. I'll do it. I think patient COVID RT-PCR positive after 7 days, living abroad. RAT test negative is a must for right. Right now, this is not insisted by the airlines, are not insisted by the most of the countries. So when the person started improving without paracetamol, the fever subsided, he can travel. There's no need for that. Asking for the safety sake, we can wear a mask. Isolation, like unisolation required it so many days. I told them minimum 3 to 5 days is fine. When the fever subsides without paracetamol, you can come out of the isolations. But the person having sick members or elderly in the family, wear a mask when you have a contact with the persons. Thanks for your compliment. Sir, how common are the radiology findings? Yes, radiology findings still existing. For example, the testing modality is same. Radiology finding, I told severity, what we used to see, the diffuse ground glass or diffuse 25 by 25 COVID presentations we are not seeing, but the ground glass opacities we are seeing there. So radiology presentation is common, but the severity, what we used to see in 2020 is not existing nowadays. Protocol for infection control measures, you need to identify one case in the ward. Suppose if the numbers goes up, because we can't mingle, because people will doubt, people will question you that why you keep the COVID cases next to me. I got COVID because of you transmitted. These things will happen. Usually keep in a single room. That's more important. Identify a separate area in the hospital where you can keep admitting the patients 3 or 4 beds. You can keep depending upon what number of cases you are getting it right now. It's easy for you to cohort also. All COVID positive patients you can keep in one ward so that you can use minimal resources and provide a good care. But most important thing, only patient needs admissions, for example, oxygen or something admit. Don't all COVID positive, like all dengue patients are admitting, no. So these things we need to restrict that. Somebody, I'm not able to hear the voice is slightly on lower side. You can type it, it's more important. What are non-respiratory complications? Yes, people are worried about seizures. For example, one of the WhatsApp group we have discussions, people are complaining the seizures also. Not only the children more tendency to develop seizures, but adults also say the seizures. Encephalopathy manifestation is happening. More of encephalopathy, more of seizures. The brain involvement is more common, and diffuse myalgia and body pain. Some amount of cases of kidney injury, particularly patients who got based in CKD, slight worsening, acute kidney injury on CKD is also reported. Major cardiac stroke complications, so far this variety we are not seeing there. Yes, few residents and doctor guessing need to focus on infection control practices. Yes, that's why I said wear a mask. Again, mask up needed. So we need to wear at least surgical mask, not N95 mask. Low BP, chest pain, lack of sleep, and COVID positive. Patient never seen in OPD. The person has got any. The first thing is assess the severity. How to assess the severity? We told in our presentations. Do the simple Q-SOFA score. Assess the vital parameter. Respiratory rate more than 22. Systolic BP less than 90. Altered mental status. Either you need to be closely monitored or closely observed or admitted. So that rate you can use it. For COVID, in addition, you can use oxygen parameters also. How much oxygen is required. Yeah, the WhatsApp group is still not activated. We're filling it up. That's why I said, please hold on. The newsletter is coming up. The WhatsApp group is also activated. We are removing all the non-doctors from the group because a lot of non-doctors also, a lot of PharmD guys, a lot of PhD doctors also join the group. So we are streamlining. That takes some time. That's why we're taking time and removing it there. So be patient. By this month, then we can do these things there. So I think we are almost 7 minutes overshooted. Thank you. So I'm getting calls. I'm getting a mail from the AP ICP chapter asking to prepare your questions for the examinations. So questions are going to prepare and exams is coming. Please start preparing. Those who registered for the certificate course, please attend. This is not a big certificate program. Definitely people who attended all the sessions, people who read about the sessions, definitely it's easy for you to clear the examination. This is not a big deal. So please try and attend the examination. It's going to happen. I expect it's going to happen in July end or maybe in August because another 4 to 5 more weeks is pending. We got other specialized sections. Now we finished how to approach infections and OP, that's finished. Then we talked about the syndrome. We talked about the IP. Now we are moving to the specialized topic like emerging and re-emerging, HIV, transplant infections, infections control, and finally, zoonotic infections are coming up. These are 4 or 5 sessions is pending. Afterwards, once the sessions is over, the exams is going to come in another 4 to 6 weeks time. It's going to happen. So please try to make enter the exams and see how it is going on there. But people who attended the sessions, people who read the sessions, definitely it's not a big deal for you. It's going to be a good certificate program given to AP and ICP. And we are bringing this whatever sessions as a modules also. Don't worry about it. We are not going to just close the sessions by doing only PPT. We are bringing the modules also. That's what asked the AP again. So we're bringing the module also. Don't worry about it. And the exam also there. Yes. We send the soft copy and we provide the hard copy to the participants' physical audience and soft copy to the Gmail ID. I think the Gmail ID are sending. Some of the people it's not going. If you want to give the Gmail ID, we can resend again. It's not a problem there. This is basically they ask to prepare by MCQ based type only. The MCQ based type only. They ask by API. I need to check with the API whether they want to have some more theory. I need to check. But so far they asked to prepare MCQ for based upon the sessions. So I asked faculty so far who did the sessions to prepare the MCQs. There are MCQs in preparation there. It's not by me. All the faculties are preparing it there. Not here, but you send it to the 98846, that number that's better in there, so that we can send, because it's very difficult for me. This is not my Zoom link. This is by the API ICP. So please send to the number. So I can there you can post your Gmail so we can send it there. Particularly people who register, it's more important, not for the short courses. Who are registered for the ID algorithm CV webinar mode and for a prime session, yes, we are going to provide the soft copy, not for everybody. Okay. And with that, I'll thank the sessions. And next week, probably infection control part will take in care. Thank you very much. I sincerely thank AP and ICP for providing this wonderful opportunity. See you next week.